on to our honored speaker, Dr. Shekhar Challa.
Thank you, Jackie. Hey, welcome everyone. Hope you all can hear me. I'm going to get my slide started, but again, like Jackie said, hopefully we'll all have a virtual meeting pretty soon. But I'm going to get started with my slides here. So let me start off with asking 3 GI questions. Eating popcorn causes diverticulitis. Spicy food causes ulcer disease, and fatty liver is a benign condition. Which of these are true? I'll give you a few seconds to think about it. Answer to yourself. Well, these are all trick questions, okay? None of them are true, all are false. So my task today, over the next 15-20 minutes, is try to go over why fatty liver is not a quote-unquote benign condition, and explain to you all and make a case for never ignoring fatty liver. Okay. So fatty liver is a loose term. So just like we say headache, abdominal pain, fatty liver is a loose term. So many things can cause fatty liver. Like for example, alcohol. So I'm not going to talk about other causes of fatty liver disease. I'm not going to talk about alcoholic liver disease. What I'm going to concentrate today is what we call NAFLD, NAFLD, non-alcoholic fatty liver disease, and NASH, which is non-alcoholic steatohepatitis. Well, this is a busy slide, but I'm going to slowly break it down for everyone. If you start at the left end of the screen, which is a healthy liver, given enough risk factors, one can develop NAFLD, non-alcoholic fatty liver disease. So when people with non-alcoholic fatty liver disease are progressing, there is liver cell injury, inflammation, and ballooning, and repeated insult to the liver with inflammation causes scar tissue, which is fibrosis. And fibrosis could be F1, F2, F3. And extremes of fibrosis is when we call cirrhosis of the liver. So healthy liver, NAFLD, NASH, and cirrhosis. And all of us here have seen what we call decompensated cirrhosis. You know, when cirrhosis progresses, one can develop jaundice, ascites, GI bleeding from varices, and hepatic encephalopathy. So the bottom half of the screen gives you a cellular level depiction of what I've just talked about. So left side, normal cell, normal hepatocyte, normal liver cell. And then the second one is when you are getting fatty liver. Large droplets of fat are accumulating. And the third one is repeated insult and inflammation is causing scar tissue. And you start seeing liver cells die. And then extremes of fibrosis or scarring will give you cirrhosis of the liver, which is the right last fourth part of the slide. So the key question here is, how often is this happening? Well, we used to think, even up until 15, 20 years ago, we used to think it's a very rare, oh, you have fatty liver, don't worry about it. But not anymore. It's very clear that this is happening way more often than what we thought it was. And here are the numbers. They are pretty staggering, right? So when NAFLD patients get inflammation and scar tissue and go to NASH, that's 30 to 50%. So a third to half of the people with NAFLD progress to NASH. And 20% of these people go on to cirrhosis of the liver. So that's a very large number compared to what we used to think. And 2.6% of these patients progress to liver cancer. In the background of cirrhosis, they can develop liver cancer. So that's 2.6% per year. That's why we do periodic every 6 months, ultrasound or CAT scan, alpha fetoprotein. You know, we want to catch these patients early because that puts them in a different trajectory for surgery and liver transplant. It's rare, but occasionally we do see HCC without the cirrhosis component. So this next slide is showing us the US prevalence. Basically, what it's showing is how bad the fibrosis is and what the mortality rate is. So when you go to the right side of the slide, when you get to F3, it's around 8%. But once you get to F4, which is cirrhosis, the mortality rate is 23.3%. So time to progress from normal liver to F4, given the right conditions, average is only 7 years. And decompensation happens in 5 to 10 years. With increasing obesity, increasing diabetes, we are seeing F2s and F3s in teenagers now. By the time they get to F4, we have seen 20-year-olds with F4, and we have seen 27, 28-year-old with end-stage liver disease decompensation. That is not common. The hospitalists in the group can relate to what I'm saying. I mean, we are seeing much more younger and younger folks with this. So moving on to the next slide. Okay, so here are the risk factors, okay? Like I said, obesity, diabetes are the commonest factors, but you see this in folks with low LDL. There is some genetic predisposition. Sometimes high triglycerides can contribute. Hypothyroidism can contribute. Medications rare, but the known medications which can give you fatty liver and NASH are methotrexate, valproate, which is Depakote, and amiodarone. And then we come to the metabolic syndrome. So all of us know that metabolic syndrome, one must have 3 of these 5 factors. Large waist size, obesity, aka elevated triglycerides, low HDL, hypertension, and diabetes. So when you have more than one of these factors, it's a 1-2 punch. 1 plus 1 is like more like 3. 1 plus 2 is more like 5. So these are the people who get into cirrhosis very quickly. So I'm going to go into some facts about this spectrum of NAFLD, NASH, and cirrhosis. Let me start with NAFLD first. 80 to 100 million people in USA have fatty liver, which is 25 to 30% of the people, which 1 in 3 or 1 in 4 of us here in this group have fatty liver. I mean, that is staggering number again. And it's most common and progressive liver disease. With increasing obesity, increasing diabetes, we are seeing more of this. Well, moving on to the second stage, which is the NASH, 3 to 5% of the population has NASH. NAFLD and NASH have doubled from 88 to 94 and again from 2005 to 2008. And when you look at the numbers from 2008 to 2020, it's quadruple. So 400,000 people in the US have cirrhosis from NASH. This is just from NASH, not alcohol, not hepatitis C. That's again a huge number. So 2.6% of these people will get cirrhosis, as I mentioned. One interesting factor I came across was patients with NASH have increased cardiovascular risk and diabetes complication. In fact, there was one paper I reviewed which shows that patients with NASH have a higher chance of dying from cardiovascular risk, independent of the NASH risk, independent of the cardiovascular risk factors, than with NASH. Meaning that if I have NASH, there's a higher chance I'll die of cardiovascular than the NASH, than the cardiac problems itself. So it is most rapidly increasing indication for liver transplant. In fact, several centers, this is the leading indication. And in the next 3-4 years, I think every center will be, doing liver transplant for NASH patients as the single most indication. This is for 2 reasons. One is obesity, diabetes is increasing. 2 is hepatitis C is decreasing because we can cure 99% of the hep Cs. So how do we diagnose these patients? Well, the gold standard is a liver biopsy, but we all know it's invasive, and I'll get to liver biopsy in a second. The non-invasive test here is the FibroScan. What is a FibroScan? Well, it's a specialized ultrasound of the liver which measures fatty change in the liver, which is steatosis, and scarring, which is fibrosis. And the results are given as a number. Like normal is 5 to 6 kPa. kPa is kilopascals. So when you do periodic fibroscans, you actually can show the patient a number. Okay, your number was 9, now it's 10. You need to improve on weight loss, etc., or it's getting better. And the other reading it gives is a CAB, which is the amount of fat in the liver. The biggest challenge with getting fibroscans, unfortunately, is it's not covered by most insurances. We are lucky that at KMC Research Center, we have had this for over 4 years. And it is a non-invasive test. And I believe we are still the only location in Kansas which has this, only because it's very expensive and no reimbursement. So number 3 is biomarkers. And for now, it is for research purposes only. Pro-C3, you must have heard, but one of these days, one of these biomarkers will go mainstream. So we could do FGF21, CK18, ELF score, and FIB4. So MRI is also a good way to diagnose how much fat there is, how much fibrosis there is. Unfortunately, none of the newer MRIs have software or approved for this because they are too fancy for doing this. The only MRIs which can do MRI PDFF and MREs are GE and Siemens. And we were getting ready to doing a study but then COVID hit with our St. Francis MRI machine, but COVID hit and hence we couldn't get that going. So let me move to liver biopsy for a few minutes. Well, I can say this, because of the research center, we have done more liver biopsies in the last 2-3 years than the last 30 years. We're keeping radiology busy, keeping radiologists busy, because we are sending a lot of folks for liver biopsies for study purposes. So once you do the liver biopsy, what you're looking for is the degree of inflammation. And there is a thing called NASH score, which is non-alcoholic liver disease activity score. So you get scores for steatosis, 1 through 3, depending on how bad the liver is infiltrated with fat. You get a score from 0 to 2 for ballooning and 0 to 3 for inflammation. When you add these all up, 1, 2, 3 part of it, and if it's a 4 or 5, you will qualify for a study. And then, of course, fibrosis. Fibrosis could be 0 to 4. One of the newer things which is happening in pathology is, and this is for the pathologists in the audience, I'm sure they know this, it's a AI-based, artificial intelligence-based digital pathology. It's the next big innovation, I guess. AI in general is the big innovation. I was very threatened about it, but then we just got what we call GI Genius, which is a tool during colonoscopy, which increases detection of polyps. So very threatened, but at the same time, the other side of me says, if I can detect more polyps just because of AI, which has looked at millions of these, then it's good for me, good for the patient, good for the cause. So, and at the end of the day, we are needed as physicians. So AI is going to take over lots of areas of medicine, and we probably ought not to be threatened by it. Technology is helping us get to the next level. So how do you treat these patients? Well, no medications for it approved. Herbs are no benefit. Vitamin E at 800 international units a day. It improves the NAS score, but does not improve fibrosis. I don't know what that means. I believe it's not going to hurt. It might help, is the best I can say. So how do you treat them for now? Well, treat the underlying cause. Weight loss, for example. All the bariatric surgeons in the group can relate to it, that after weight loss surgery, even if there are cirrhosis of the liver, it regresses. I've seen so many patients 20 years after weight loss surgery still are doing fine. So weight loss is good, controlling diabetes is good. So where does that leave us? Well, there is a race to finding a treatment. over 25 locations, 25 studies are going on in our country, and probably another 25 internationally. The number might have increased even since I looked at it a few weeks ago. The one thing I'm proud of is we at KMC Research Center, we are doing 10 of these studies, and we are probably the highest study center for NASH in the Midwest. If not the highest, probably the second highest. We are neck to neck with another center. We are getting ready to do another study for Indonesia, and we are also been asked to be a consultant in an outlier study for a major pharmaceutical company, which we are proud of because based on our feedback, they are going to do the study protocol. What is an outlier study? Well, why are people with diabetes, extreme diabetes, obesity not developing NASH? That's one end of the spectrum. And why are people with no risk factors getting NASH? Well, that is the outlier study. So these are the 10 studies we are doing. Okay, we are doing studies for Pfizer, Viking. Well, I'm not going to bore you with what all studies are doing, what phases we are doing. Rest assured, we are doing a lot of these studies for NASH, and we are getting one more study, as I mentioned. So we are doing anywhere from F1s, early NASH, NAFLD, NASH, all the way to cirrhosis. So the whole spectrum. So this is, I have only 2 more slides left. This is the summary. So the major takeaways. Okay, number 1, fatty liver seen accidentally on sonogram or CT scan in 2021 should not be ignored. That needs workup. Number 2, liver function tests are not a poor man liver biopsy. They are not a good indicator of degree of liver damage, right? We all have seen people with normal or near normal LFTs, but they have cirrhosis already. And we have seen people with high LFTs who hardly have any liver disease. So the liver function tests are not a good indicator of liver damage. The other thing is, this is for the cardiology providers in the group. Patients with NASH have an increased risk of cardiovascular disease. And finally, for a limited time, we at KMC Research Center are offering free FibroScan screenings for any one of you in the audience, or your patients for that matter, if they qualify. I'm sure several of us in this group have NAFLD or NASH. So I'm not going to end with all doom and gloom. There is some good news. Liver has a tremendous amount of reserve capacity and is the only organ in the body which can regenerate. Sometimes in months, transplant literature has shown us that within months it starts regenerating and can get back to a normal liver. A donor liver, partial liver, gets back to a normal liver in months. So for now, other than studies, counseling and waiting, counseling and of losing weight and diabetes control are the ways to go. All right, this is my last slide. I just wanted to give a shout out to the KMC Research Team. That's me and my partner, Dr. Dardy, way smarter than me. Laura is our nurse practitioner. She is nicknamed the Hepatitis C Queen of Kansas. And that is Jada next door to her. And Jada is the biologics queen, great in IBD management. Michelle joined us, a little over a year. She's like me, jack of all. She's going to be one of the queens pretty soon. And the next 4 folks are study coordinators. Susie is our lead study coordinator. She's the reason where we are today. And she is the backbone for the study center. And of course, she is helped by Kendra, Alicia, and Heather joined us recently as a research assistant and then as a lab tech. And then we are getting Alexis, who is joining us next week, actually. And to the bottom left is the superstar KMC marketing team. And actually, we are one short because she serves the Kansas City market. And we have one more person, Katie, coming, but that is Ashley. Emma is our marketing director, and Taylor. I'm going to tout them for a second. they won a national award not too long ago. It's called the Radio Mercury Award for the best creative award for KMC's colon cancer ad, along with Alpha Media and WABW. Our finalists were Dairy Queen, Geico, Progressive, Motel 6. We are very pumped about that. So that is a shout out to our marketing team. So here is our contact information. You have my name, email ID, office address, my mobile number there, and that's Susie, our lead coordinator's contact information. If you all want to refer a patient or yourself for a FibroScan, no strings attached, if you can leave the screen up for 15 seconds, if people want to take a picture, how to contact us and write down, that'll be great. But otherwise, that's it. I might have gone a minute or two over, but NASH is something which excites me lately. So I'm going to stop there.